All right, so most of the science is done. I'm here to talk about the admin core, which frankly is very boring. So I'm going to focus on the part that I enjoy the most, which is our Precision Therapeutics Academy. So we've been pretty intentional about training the next generation. So as part of MPRINT, we've had 10 trainees in our Precision Therapeutics Academy. The 7 graduates are pictured here. The 3 current students, they don't get their pictures up until they graduate. But you can see we've had a good mix of MDs, PhDs, some combined folks. Most of them enjoy it so much they decided to do 2 full years. Some have done just 1 year. And you can see most of them have stayed on at Vanderbilt. We have one guy who's now doing a fellowship at Duke. And one of our current students is actually a med-peds resident, so that's the most junior person we've had so far. But this has been a very productive group. They've had 142 publications, 40 as first author, 12 as senior author. And these are in very high impact journals, so the Nature family, the Circulation family, the JAMA family. They've given presentations at PAS, AHA, SRI, ACR, and so on. 5 of them have applied for and have received support pool funding from our MPRINT site. And so far, I know of 3 of them who have obtained subsequent NIH funding, 3 K awards, K23, a K01, and a K08. So I'm going to go over all 142 papers. No, of course not. I just threw up a few of them here, and to call this the highlights is really not true, because there are many more highlights than I have time to go over here. But here's a couple examples. One from Jim Antoon, who was in our first year with this paper in JAMA Neurology, and Liz Jasper with this paper in again the Nature family. I put Monica's up here. So Monica technically wasn't a true PTA person, but she got some support pool funding, and the PEDS fee codes project has been very successful, so I put that one up there as well. You can see some PK modeling work, so I know you guys have been focused on that the last few days. This was a really cool project from Anna Patrick. So she developed a phenotyping algorithm to identify JIA in the electronic medical record, and so she did that at Vanderbilt, and then went ahead and collaborated throughout the VICE-MPRINT, throughout the MPRINT network, to validate that phenotype across EHRs. So that was the whirlwind tour of our PTA. We've got about 4 minutes left, so I'm going to have the rest of the speakers come on up here, and we will take questions until the time of our break. So Sudeep, Andrew, Wei-Qi, Megan, if you want to come up here, we'll entertain questions. Go ahead and approach the microphone. While we're waiting, I will say, I'm not sure which was my favorite slide, either the Legos that Wei-Qi had, or the Odancitron non-responder, the woman who was retching. I really enjoyed that one. Ryan, go ahead.
All right, great presentations. I really enjoyed the talk. My question is the genetic study. Sorry, I forgot which drug is, but what I remember is one of the few slides, 2 studies talking about adverse events, right? But you didn't specify which one they are. Can you tell me what's the thought process? How do you pick them? And then go from there, yeah.
As far as picking which adverse events to look at? Yeah, sure. So for the cardiac-focused drugs, really those medicines can have both cardiac adverse events and systemic adverse events. And so for the propafenone study, we actually saw that the larger kind of cohort of adverse events was actually in non-cardiac issues. So one of the more frequent things we see in our infant patients who we're treating for arrhythmias is that they actually can have kind of dyschezia and feeding intolerance. And so that was one of the more common adverse events we saw with the propafenone study. For propranolol, similarly, the medicine can be used directly to treat heart rate. And so bradycardia actually wasn't a significant adverse event that we detected, but it was more so mood disturbances and fatigue that were kind of the most common adverse events with propranolol.
Were those data or evidence from your clinical experience, or are you from existing literature or from the drug labels?
Yeah, so we included a wide range of adverse events, so essentially anything we could find within the literature and kind of reference materials. So we made sure to cast out quite a wide net for different adverse events, but then ended up seeing kind of a smaller pool of ones that popped up most frequently.
I think this is a really good area. Maybe we can explore some collaboration, because we feel when we curate the knowledge, AE knowledge from literature, we see a lot of diverse data, including labels, including papers. I think it's hard. It's very hard for us to say which ones are more important than the others. So I think that thing, really could help us to prioritize the evidence in the literature and hopefully help the other genetic study how to pick the endpoints. Okay.
Yeah, so one of the benefits of our system is we have the ability to do a lot of the work that Wei-Qi does, where it's, we provide the knowledge early. But in a lot of those pharmacogenomic studies, one of the things that we're doing is we're actually doing chart adjudication as well. And so we come in with set expectations about potential adverse events or how we're defining response and non-response, but that knowledge can change through review as well, where we see things that were unexpected at times. And so being able to marry what's known in the literature, what's observed clinically, as well as what we're actually seeing through documentation is really advantageous to these projects.
No, I know. So as I said, a lot of knowledge we try and put it together at the beginning is really from literature. So I think only afterwards we definitely go into EHR and try to figure out what we can do about it. But thank you so much.
All right, well, if there are no other, go ahead, come on.
So Tom Callahan, one of the things that I've observed as I've tried to decide whether my patients are suffering from particular adverse events is I've looked at the package inserts, and as many I'm sure of you have done, and basically we have lists of medications, and there's maybe a placebo that's equivalent and whatnot. But when you try and really decide, for instance, I've looked at people that are supposedly on drugs that are sedating. Well, how much sedation listed in the package insert is really applicable to what we're seeing in clinical practice? And so the question is, when we look at a list of 20 drugs and whatnot, how do we decide what's an important contributor that we need to control for, or maybe use as an outcome, or maybe it's a pattern that we have to look at? And I haven't seen a whole lot of work on that, and I wondered if any of you, as you've thought through your protocols, have decided how you're going to investigate those things in terms of maybe an outcome or something along that line.
Sure. Yeah. So I agree. I think it's a real challenge. Going back to cardiac adverse events, it's really straightforward to be able to say we can measure EKG intervals or measure heart rate and have a quantitative measure. But I think the subjective issues are really challenging. For instance, with propranolol and fatigue or mood issues, it's hard to know, is that related to the drug? Is it related to something else that's going on in the patient's life? And so I think that makes it really difficult to assess. What we've tried to do in the past is use, obviously the data we're using are collected retrospectively. And so we try to lean on the clinical documentation as far as if the clinician kind of reflects this seems to be related to the drug or not. And then we've also collected data on drug discontinuation. So if that kind of pushes the clinician or patient to request the drug to be stopped, then we've used that as a secondary feature.
And so while not a perfect proxy, something that we often do into our design, so for example, with the ondansetron, just kind of standard epidemiologic processing of considering multivariables and whether or not a variable is independently associated, and then actually building it into the model, opposed to just a priority making a decision. We'll even include things that we've noticed through a trend. It seems to be coming up. Is this potentially significant? And so we'll include it as an individual model variable. And so it's not perfect, really. At the end of the day, it's a best judgment, but by assessing just associative strength, it can also suggest whether or not that needs to be added into the later models and like our multivariable, which we observe some of those associations, for example, with like the cytochrome P450s, once you start accounting for all of these other variables, the signal may not be as significant. And so leaning on traditional epi principles are one of the benefits and something that we need to consider because, we include as much information as possible. We use clinical diagnosis, but even what we can get in our models, we have limits in power and everything else. So I don't think there's a perfect answer yet.
Well, I'm glad to hear I'm not alone.
No.
One last question, if I might. I'm glad you brought up the QT and the EKG changes, because we spend a lot of time reviewing the oncology team's drug lists, and it's amazing how many QTC drugs we find being listed there, including ondansetron, I might add. But ondansetron only gets used PRN, and so when does it become significant in terms of the drug use versus the time you're actually talking about QTC? But the other big pattern is that we see individuals on 4 or 5 drugs, and they may be, sometimes they are, if you use the credible meds category, they're CRs and PRs and KRs, and they're all together. So we have 5 or 6. But as far as I can tell right now, and it's not really a sophisticated look-see, I don't see any real consequence in these particular patients for them to be on all of these drugs. And the final piece, of course, is if you look at some of the literature coming out of IU or Purdue, they'll shoot me, from Dr. Tisdale, there's so much of a difference based on whether you're talking about estrogen or progesterone. So, or androgen, testosterone for that matter. So what do you particularly use for listing those things in terms of a clinically significant issue?
Yeah, it's a good question. I can go first, and I can let Prince talk since he's a QTC expert. But I think you're right that we do a lot of drug monitoring for those patients, whether they're oncology patients or other folks in the Children's Hospital for EKG monitoring, and rarely really see those adverse events of prolonged intervals. And like you said, sometimes even patients who are on multiple drugs have no real consequence of it. But who knows if that's something related to their genetic makeup and more pharmacogenomic studies that need to be performed to really understand that, or if there's something else as far as the dose or specific drug interactions that we just don't quite understand yet. But I'll let Prince add if you'd like.
So my mentor is Dan Roden, and he's probably the world's expert on drug-induced QT prolongation, and he introduced the concept of reduced repolarization reserve. And so concept is that individuals have a lot of biological redundancy in maintaining the QT, and it takes quite a few perturbations to actually cause a problem. And I just think this is completely just anecdotal, but I think children in general have tremendous repolarization reserve. It's very hard to get significant QT prolongation that actually causes arrhythmias in children. Now if they're septic in the ICU and they're on 50 QT prolonging drugs, maybe. But the kid who has 2 or 3 medical problems and they're on 2 or 3 QT prolonging drugs, it's not a significant problem.
All right, I'll come back for another question. So the AEs actually are not necessarily very simple, phenomena. There are like mild symptom, there are severe symptoms. As a consequence, medication has to be discontinued, maybe reduced the dose, right? I'm glad you mentioned the discontinuation. I think my question is, given the fact that, there are symptoms, early symptoms, maybe later symptoms plus genetics, have you guys thought about it, developing a model using genetics and maybe using early symptoms predict, say, discontinuation, which is actionable, right? I think this is something I would, entertain. In my lab, we want to do something about it, but not just in the pediatric setting. But I see this could be a potential, really good, things you guys can do. I just, bring it up.
Yeah, so I can speak to that, and unfortunately not in much with maternal medicine and pediatrics, but I have looked at discontinuation. One of the limitations we have in EHR is actually classifying discontinuation or non-use of med. Yes. So that is a limitation of any of our studies doing that, so I want to say it straight out. But I have done various projects looking at medication change for depression or blood pressure responsivity, and looking at predisposition to either renal clearance as well as just risk for a particular condition and severity. So with blood pressure, using polygenic risk scores. And there's a lot of interest in looking at, can we predict discontinuation or prioritization of medication based on that? So the field is evolving in that way, and there is a lot of untapped resources for it. And so I can say I have not specifically done this in maternal or pediatric medicine, but there are opportunities for it. But the biggest thing, especially even what we've seen in the simple study designs like the ondansetron or the propranolol, the numbers are still small when we get to individual sites. So getting buy-in, the beauty of the EHRs is you have such a robust data set and the ability to increase the numbers. But when you start complicating this by including genetics and other variables and discontinuation, that's where we really need multiple sites to do this complex algorithmic determination of responsivity and adverse event profiling. And so, yes, I've thought about it. Happy to talk about it more. I have various projects on it, but unfortunately most are in adults.
Yeah, and I'll just add, I think one thing that Sarah Van Dries taught me is it's really important to look at the extremes. And I think, like Megan mentioned, even in our cohorts with hundreds of patients in these various studies, we still have very small sample sizes of patients who are poor metabolizers or ultra-rapid metabolizers. And those are really the numbers that it would be nice to bolster to understand, because those are probably the individuals who are at risk for needing to discontinue the medicine either due to inefficacy or an adverse event.
I know we're coming on a break, but I'm just going to point out Phil Wilson's comments that have been popping up on the chat up there. The issue we all know is we have with EHR data is it only captures what the doctors put in it. And so he was asking about, making that comment that, a lot of times for SSRIs, they don't capture sexual dysfunction or bad dreams with propranolol. And then also another thing was the hypoglycemia with propranolol, whether you captured that as a side effect, and makes the comment at the end that often it's WNL, we never looked. So.
Yeah, I think my comment about that is actually, this is true, partially true, I would say. If this is super, super important about the patient, that will be a conversation between that patient and the PCP as well. So another thing I want to mention here is, EHR is great. That's healthcare, reliable, gold mine, you want to mine. But another thing I want to add actually is that, we probably need to look beyond. So I like the hypothesis actually is that we have a lot of social media information. For example, I heard we have a study actually to start to find what the most concerns when patients start taking, for example, statin, right? You can go to the social media and looking for what their complaints using whatever mathematical approach, or right now we can apply AI approach as well, right? To find out what is a potential signal and try to validate that signal in EHR.
So I'll just add one other point along the lines, because we're talking adverse events. I recently read a paper where they're actually looking at these other data resources, and they're actually looking at potential adverse events for cancer therapeutics, and they're actually using Amazon data and Amazon ordering. And so reviews by patients who've said, I've used this this like a hat because of my cancer treatment, and it really helped with me feeling warm because of my head. And so there's a robust set of data that's secondary to EHRs, echoing Wei-Qi's point that we can actually mine, and people are mining to better understand adverse events.
Google is probably the winner at that right now.
Yes, the comment on mining social media for data, that kind of raised an important consideration in my mind. A lot of social media now is sort of like AI-generated content and engagement. So has that been addressed in the field? And that seems to be increasing over time. So how is that like, oh, if I put all these reviews in about my hats, generate all this stuff about my hats and cancer treatment, that could be a signal that gets pulled out and then, used in marketing or some type of claim. So is that being discussed?
Well, so my quick thought about this. Number one is the timeline. Right, that's number one is the timeline. And number two is, AI is AI. Somehow, when I read more papers about, human, editor versus AI editor, somehow I can feel like, this is a AI. So I guess, eventually we can come up with a smart way to figure out what happened there. And another thing I will mention, when we talk about social media, it's a kind of like a no governance, whatever you want to put up there. But we may have like a, FDA may have the self-report data there. We may have some, eventually we'll probably have some website to say, if you want to report your side effects, go there. But we're going to check your data quality, make sure you're human. Eventually, we can come up with. And another thing is, like they said, is, it's when people type in what they're looking for drug-to-drug interactions, that won't be fake. This is just, it's looking, check the logs. Microsoft did that, Amazon did that, Google did that as well. Yeah, eventually, my argument is going to be, we got to figure out how to tell the difference. But that's a very valuable resource. And the final thing I want to add is, eventually, once we identify that signal, that's just the data source, then we need a validation. We got to go to EHR, go to a different EHR, combine multi-omic data to confirm that. That will be the final conclusion.
Yeah, so I'll echo, it's a conversation in the field that we know AI hallucinates. There's problems with it. There are concerns about using it. You have people on both sides of don't use at all, only use it, trust it. I think it's going to honestly come down to exactly as Wei-Qi says, some balance of where we will start to understand what a hallucination looks like. We can start to ask questions about it, and then we can balance that by basically standing up results with a more validated instrument.